webinar series of Association for Harm Reduction, Education and Research. For this month's webinar series, we are delighted to be joined by oral medicine expert, Dr. Jayashree Gopinath and Mr. Asa Saligupta from Thailand. And to introduce our esteemed panelists, I'll take a minute to briefly introduce both of them. First of all, I would like to invite Dr. Jayashree to join us on today's panel discussion. Dr. Jayashree Gopinath is an M.D.S. oral medicine and radiology specialist currently affiliated with Ragas Dental College in Chennai. She completed her B.D.S. degree from Tagore Dental College, affiliated with Dr. M.G.R. Medical University, Chennai. Her clinical experience is budding and she currently has multiple affiliations with private and academic institutions. Recently, she has highlighted the importance of tobacco harm reduction as a public health strategy in high burden tobacco usage countries like low middle income countries, including India. Madam, we welcome you for today's monthly webinar series hosted by Association for Harm Reduction, Education and Research. Thank you for accepting our invitation.
Thank you, Dr. Suchitra.
And we invite our second speaker and panelist for today's session, Asa Saligupta. He has multiple affiliations and presently the director and founding member of ENDs Cigarette Smoke Thailand, ECST. He was a former smoker and he is been successful in quitting smoking using vaping product. And he's an avid advocate for tobacco harm reduction who resides in Thailand, the country that prohibits importation, distribution, and manufacturing of vaping products. But ECST is a consumer group that was founded a few years ago when vaping became illegal. He completed his high school education from England and bachelor's from Thailand University and master's from United States of America. We are extremely delighted to have you with us, Asa, and we welcome you for today's panel discussion. Thank you so much for accepting our invitation.
Thank you.
Yeah. So I would like to now invite Dr. Jayashree Gopinath to make a brief presentation about her topic and today's topic. What is the impact of tobacco policies in India and what could be the way forward? Madam, can you share your screen?
Yeah, thank you. Thank you, Dr. Suchitra, for giving me this opportunity. Now I would like to give a brief introduction about the tobacco control policies in India, how it got implemented and what are the present challenges there. As we all know, tobacco is a major public health challenge in India with 275 million adults consuming different tobacco products. Not only cigarette is the only tobacco product that is commonly consumed in India, even BD is the other commonly consumed tobacco product and we are not aware of it. And again, India is the second largest consumer and the producer of tobacco in the world, next to China. And the prevalence of tobacco use among adults in India is 35%. And the prevalence of overall tobacco use among males is 48% and among females is 20%. And nearly 2 in 5 adults in rural areas and 1 in 4 adults in urban areas use tobacco in some form. Tobacco means not only cigarettes, it also includes smokeless tobacco forms like gukka, pan masala. The challenge posed by tobacco has been encountered by different countries with various levels of success. In case of considering the Asian countries mainly, first in Southeast Asian countries like Bhutan, Thailand, and India, they successfully enforced the smoking ban in the public places. And Bhutan is the first country in the world to impose a total ban on tobacco product sale and use. And again, China introduced a smoking ban in public places in Beijing from May 2008, following the Olympic Games, and it came into effect only from 1st May 2011. Again, Singapore has some smoke-free legislation since 1970, but it has strengthened it recently. Even Hong Kong enacted the smoking ban law in 1982. but it could only enforce it since 2007. And what are the other Asian countries that have banned smoking in public places, but the implementation is far from the complete ban? Like Indonesia, Kazakhstan, Malaysia, Bangladesh, Pakistan, Philippines, and Vietnam. Talking about the tobacco control legislation in India, the growing evidence of harmful and hazardous effects of tobacco, the Indian government has enacted various legislation comprehensive tobacco law measures. Mainly, the first one was the government enacted the Cigarettes Act, the Regulation, Production and Supply Distribution 1975, under which you can see the statutory warning like cigarette smoking is injurious to health was mandatorily displayed on all cigarette packages, cartons, and advertisement. And even now, a recent law says that from 2012, it should cover 85% of the front and back panels of the tobacco product package. Again, under the Prevention of Food Adulteration Law 1990, even the statutory warning regarding harmful health effects should be made mandatory for pan masala and other chewing tobacco products. Again, in 1992, under the Drugs and Cosmetics Act 1940, the use of tobacco in all dental products was banned. The Cable Television Networks Act 2000 prohibited tobacco advertisement in state-controlled electronic media and publications, including cable television. Between 1997 and 2001, several litigations were filed for individuals' right to smoke-free act and 5 states responding with smoke-free and tobacco control legislation. So this led to the Government of India to propose a comprehensive law for tobacco control. Following which the government enacted the Cigarettes and Other Tobacco Products Act, that is Prohibition of Advertisement and Regulation of Trade and Commerce Production, Supply and Distribution in 2003. Under which these things come, first thing is prohibition of smoking in public places, then prohibition of advertisement of tobacco products, prohibition on sale of tobacco products to and by minors, ban on sale of tobacco products within 100 yards of all educational institutions, and mandatory display of pictorial health warnings for tobacco products packages, and mandatory testing all tobacco products for a tar and nicotine content. Again, in 2004, the Indian government ratified the WHO Framework Convention on Tobacco Control, and it enlists the 3 strategies for both in demand and supply reduction of tobacco strategies. What are the demand reduction strategies? Like taxation, price and tax measures, and statutory warning, comprehensive ban on advertisements, promotion, and sponsorship, then tobacco product regulation. Again, supply reduction strategies were combating illicit trade, providing alternate livelihood to tobacco farmers and workers, and regulating the sale to and by minors. Following these 2 laws, they came into force the National Tobacco Control Program in 2007 to 8. This is the framework of the National Tobacco Control. It works under the Ministry of Health and Family Welfare Government of India, and it is again divided into National Tobacco Control Cell, under which comes the State Tobacco Control Cell and the District Tobacco Control Cell. Mainly under the National Tobacco Control Cell, it takes care of the public awareness about the harmful effects of tobacco, and tobacco testing labs were created throughout India. And then this National Tobacco Control Program was integrated along with the National Rural Health Mission to reach the rural areas, and they were also discussing about the alternate crops for tobacco farmers. And then the Global Adult Tobacco Survey was conducted. So what are the main activities of a state and district level tobacco cell control? Monitoring the tobacco control laws at both state and district level, and training the public health workers and NGOs. Then IEC is nothing but information, education, and communication activities. Later they conducted school programs. And another one important thing was the tobacco cessation centers were created. The WHO Tobacco Free Initiative India, it comprises of mainly setting up of tobacco cessation clinics. These tobacco cessation clinics, they help the correct users to quit tobacco in scientific manner. So these tobacco cessation clinics were mainly placed in cancer hospitals, in psychiatric hospitals, then medical colleges, and even some NGOs run those tobacco cessation clinics. Now they have been extended to regional cancer centers, and there is also a resource center for tobacco control in India. These tobacco cessation clinics were the first initiative, a bigger initiative in India, which was conducted along with the help of WHO. Later comes the Empower Initiative. What does Empower Initiative mean? Monitor the tobacco use and prevention policies, and we have to protect the people from tobacco smoke. It talks about the second-hand smokers and offer help to people who want to quit tobacco. Then warn about the dangers of tobacco and enforce bans on tobacco advertising, promotion, and sponsorship. And we can also even raise the taxes on tobacco. Actually, these two initiatives had a very good impact in India, anti-tobacco control laws. Apart from this, the other measures that were taken by the Indian government is creating awareness regarding the anti-tobacco laws. And there was also a national inter-ministerial task force for tobacco control. In this case, they were working, two or more departments were working together, like the Ministry of Health and Welfare along with Agriculture Ministry. They worked together. Then alternate livelihood initiatives for BD rollers. They were given training for other alternative jobs. And then one major important thing in the health industry is the integration of TB and tobacco control initiatives. As we all know, it is one of the main cause for TB. Then mainstreaming the tobacco control in medical and dental education is in the country. Actually, as health professional, we should be the person who first addresses this issue. And we have to say to people regarding what are the harmful effects of tobacco, and you have to make them quit tobacco in a scientific manner. Then a national tobacco control helpline was created, and national consultation on smokeless tobacco was later on created. When we talk about tobacco control, mainly people focus only on cigarettes. In recent times only, they have been talking about the smokeless tobacco forms. Then the other laws that was passed recently are the regulation of food safety and standards regulation by the Food Safety and Standard Authority of India lays down the tobacco and nicotine should not be used as ingredients in any of the food products. As such, Gupta is also banned. The Jubilant Justice Act 2015, it gives a cause to be given to any child, any intoxicating liquor or any narcotic drug or tobacco products or any psychotropic substance, except on the order of a duly qualified medical practitioner, shall be punishable with rigorous imprisonment for a term which may extend up to 7 years and shall be liable to fine which may extend up to 1 lakh rupees. Later, the prohibition of electronic cigarettes, production, manufacture, import, export, transport, sale, and distribution, storage, and advertisement act was passed in 2019. Actually, e-cigarettes are completely banned in India. So, what are the shortcomings of these anti-tobacco control laws in India? See, they mainly place this taxation or they increase the price of the exported and imported cigarettes. But there's no kind of taxation on BDs and smokeless tobacco, and they are mainly used by lower income group people. And there was a spurt of so-called advertisements of pan masala, even in mass media, as you can see. And the permission for smoking in designated areas of restaurants, hotels, and airports, and display of advertisement of tobacco products in stores and stores are placed. Till now, there is no law to control these things. The existing penalties seem to be very insufficient. When you caught being smoking in a public place or like the advertisements regarding tobacco products, the penalties are very less. In addition to making tobacco products more appealing, they also reduce the irritating character of tobacco smoke, actually, which encourages the use by many minors. So these shortcomings have not been addressed by any anti-tobacco law in India till now. This is one of the proposed Cigarettes and Other Tobacco Products Act in 2020. Actually, it bans smoking-free areas in restaurants and other places. And apart from them, they are raising the legal smoking age from 18 to 21 years. There are other shortcomings like it seeks to disallow the retail sale of loose sticks of cigarettes, and it prohibits the sale of tobacco products to persons below 21 years, but put controls on in-shop advertising and promotion. And the proposed amendment in the tobacco control law are more likely to increase only the illegal tobacco trade in the country, thereby increasing tobacco consumption instead of discouraging it. And the focus of the bill is mainly on cigarettes, but the most prevalent form of tobacco consumption in India is not cigarettes. It's smokeless cigarettes and BDs, and which has been completely avoided in this bill. I think I have given a brief introduction about how the anti-tobacco control laws are being enforced in India.
Yes, madam. That's a very really comprehensive outline about the various, moreover, like a historical evolution of tobacco control policies in India till date. You have also mentioned the proposed
amendment is still yet to be passed.
Yes, which are supposed to be passed for legal status. So now I invite both the panelists to be joined in this panel discussion about what could be the future of these policies, given the highlighted points like the majority of tobacco consumers in India are smokeless tobacco users, especially the low-income groups. It looks like the policies are directed towards smokers, cigarette users and smokers. So now I would like to, because we both are Indians and we did understand like what is the evolution of tobacco control policies in India. For a minute, we would like to listen to the international guest, Asa, and take his views, like looking at a bird's eye view of tobacco control policies in India. What is your impression, Asa? Is it comprehensive, and is it covering the entire range of issues we are facing as a population having a high burden? As madam has highlighted, we are having almost like nearly 300 million tobacco users in a country with the 1.3 billion plus population. So the range of policies which Dr. Jayashree has highlighted in her presentation, what is your major observation?
First of all, I'm quite surprised that India and Thailand, we the policy makers, they tend to go towards the same goal with by going through the same pitfalls. You know, like India just follow Thailand only 2 years, right? The implementation about smoking ban in public places, for example, and what really surprised me was one of the things you mentioned. You know, the strategies and the way our countries, I really want to say, half blindly follow FCTC, the WHO FCTC. You know, like they want to implement the price, increase the price, increase in taxation. You know, put in this that you show the plain packagings. You know, all those warnings. Speaking from former smoker, I smoked like for 37, 38 years, so I passed through all of these policies, starting from, you know, like the packaging that we see, the regular no warning at all, and small warning, large warning, until like almost completely 100% warning with just a very small brand. But I quit before that. I quit about 10 years ago, so luckily, you know, I consider myself lucky. And the ban on advertisement and or promotions, I kind of agree with that. I mean, I'm not saying that I totally disagree with policymakers, and one of the things that I don't know if I, I I had tried to warn our government in Thailand, say, if you raise the tax and the price of cigarettes, the buyers, they don't care how many percentage on the tax for the original price. They just their only concerns are what they have to pay for a pack of cigarettes or a carton or just one cigarette. And if it went too high, then they would definitely go to black market. And that's one of the things that's okay. I'm saying that you can't get rid of black market, more or less. But the higher the taxation, the bigger the black market will be. And that includes everything else in between, not only the price of a regular cigarette only. And you had mentioned, like one of the shortcomings is that the taxation and everything is pretty much aimed to tobacco, regular cigarette, smoking cigarette, but not counting BDs and smokeless tobacco. And right now they are breathing down on vaping as well. And what's funny was at COP right now, it's going to be COP9, right? At COP7, that's if I remember correctly, it was in Delhi in 2016, in 2016. That was probably COP7, and a group of doctors from Thailand tried to convince the parties, the attendees, saying that, hey, let's ban vaping. Or got opposed, but seems like the host India listened to doctors from Thailand without looking at the scientific researchers and results, and just saying that, yeah, let's ban it. Why not? And it went back to belong to the existing policies that, like you also, but at the end of your slides, you also mentioned like you said that you mentioned the penalties. I think if correct me if I'm wrong, but you think that the penalties is not strong enough. Uh, that's one of the things that I would like. Okay, this is what my point of view is, that maybe it is severe enough, but the government, they don't have authority to strengthen that the penalties, to go find people. They don't have enough personnel and people to enforce that kind of regulation. So you can say, like, hey, if you smoke in school, you will be prosecuted. They will kill you. People will still smoke in school because they said, hey, I smoke in school, so what? Nothing's gonna happen. So it's not the severity of the penalties itself, but it's also the act. And if you educate people enough, then I think that's one of the things that are lacking in the policies, both in India and in Thailand, in my country. So that's my two cents.
Yeah. Thank you for sharing your thoughts on all the range of tobacco control policies and the comparisons between India and Thailand. Now, I have read this article, and all of us in this panel, I have shared the link about Dr. Jayashree's latest article on impact of tobacco control policies in India. And especially she mentions about providing access to safer harm reduction alternatives. Dr. Jayashree, can you let us know what is your experience with the tobacco harm reduction alternatives, or how did you perceive this tobacco harm reduction as an alternative in your clinical practice or in your academic research? Can you share those experiences with us?
Yeah, sure. Tobacco harm reduction practices are actually, they are not doing so good in our country. To be very frank, actually, though we say patients regarding the nicotine replacement therapy and to go for counseling, actually about the tobacco cessation, counseling is the first basic thing which we do with the patient, but they never listen back to it. That's a very important thing. And not many hospitals in India actually have the tobacco cessation clinics. Not even in a government hospital, to be very clear. So actually there are many replacement therapy instead of to use a nicotine. Even I support in some cases about like e-cigarettes. Though there are two stands regarding the usage of e-cigarettes in India, but it is banned in India. But still, I can see people using e-cigarettes. So there is not like something that we can completely ban it. Some people are very comfort in using e-cigarettes compared to cigarettes, and they are in the verge of quitting it actually.
Yes.
So that cannot be taken in a wrong manner. At the same time, when you actually see patients who are using like smokeless forms of tobacco, the other very hard out of people to convince about the harmful effects of tobacco. Basically, they come from lower economic situations. And when we say them to stop using these forms of tobacco, they won't listen back to us. And later on, they develop many oral lesions. And when they come to us, actually, they will be in a grade 1 or grade 2 kind of oral cancer. Mainly, we see the cancers of tongue and cheek. So, in that kind of scenario, government should come forward and take they should take forward the tobacco cessation clinics even in a practical manner. Actually, dental institutions have a tobacco cessation clinic, but they are not effectively working. That's what I want to say.
Yes. And also, Doctor, in your article, you have mentioned that some of our tobacco control policies are not delivering to the, as you correctly highlighted, to the real practical needs of the tobacco consumers, right? And when you as a clinician are in favor of offering multiple choices, like you said, even though there are two different schools of thinking regarding e-cigarette usage in practically assisting people in quitting tobacco, why is that government not hearing to that evidence or the clinician's voice in country like India with almost 300 million tobacco users? Why is that? What could be the reason? Because your article clearly highlights the importance of addressing the needs of the consumers.
Actually, that could be because of the traditional tobacco farmers. Actually, our country came forward to ban e-cigarettes. It's mainly because of the pressure from the farmer side. Because they want the tobacco, both smokeless form of tobacco and cigarettes to be in use, but they don't want e-cigarettes. Basically, e-cigarettes are not produced in our country. They are actually exported. So mainly, I think that is a political reason, maybe.
Asa, can you come in and try to help us understand why, because this issue is not really located in India, why governments all over, especially in low and middle income countries, developing world, they are not in favor of newer technologies and tobacco harm reduction strategies? What could be the reason?
Probably from what I face, and not just only in India and Thailand, but in many countries. One of the reason is because of the lack of true knowledge. Like there had been suggestion lately saying, because we have tobacco farmers coming out, going to the parliament and saying, hey, the tobacco manufacturing company here in Thailand, which is one of the biggest, and they're not buying as much. I mean, right now they are buying 40 to 50% of the total crops that the farmers put out. So they came out and say, okay, how would the government help us? And one of the doctors came out and said, well, that's easy. Let them plant something else, which it's easy to say, but it's not easy to do. Like I can tell Dr. Jayashree say, well, if you can't have any patient, then why not go I don't know, do something else that is not becoming, not as a doctor, but open a restaurant instead, something like that, which is, it doesn't make sense. And yesterday I was at the parliament in a meeting, and I found out, this you might be surprised that, people can die by quitting smoking, like, quit cold turkey, because that will bring stress, and stress can kill you. Stress can cause a heart disease, cardiac arrest, and things like that. And this is coming from specialists in heart disease field, coming from the mouth of a doctor. He said, yeah, there are cases that, you force people to quit and they die. So, stress is also a factor. So, the government, I think, if they are good government, they have to really think everything through, and also have to consider, you have, like you said, 300 million, right, tobacco users. We have like about 10 million smokers. So, I mean, compared percentage, you're probably not much different because you have more populations. But these are quite a big number. So, like, I still don't understand why the government sometimes they just, I have heard a word at a meeting about 4 years ago with the government agencies, and one of the doctors said that once you pick up a cigarette, then you don't have any right at all, not even basic human rights. You lose that right the minute you pick up and light up a cigarette. I was like, so maybe that's one of the reasons. Maybe they don't care. I don't know. But they should care. But that's one of the problems that both our countries will have to face, and we have to look into that. And the quit clinic, right? The clinic, cessation clinic that help people quit. Here, I don't know. In India, I've never been to India, but I went to a cessation clinic in the States, in United States, and didn't help me quit. And especially in Thailand, they suggest that, well, you can go try and pray, meditate, and and also they advise, like, okay, have your loved one pray for you that you just like, or chew on a piece of lemon lime. So, sometimes it seems really silly.
So when you are mentioning earlier about people dying in the process of quitting cold turkey, you wanted to draw attention to the fact tobacco quitting should be assisted with a professional help, and the consumers planning to quit should be provided all the necessary tools, like Madam said, behavioral counseling, cessation counseling support, and also the nicotine replacement therapy tools, and all the other tobacco harm reduction accessories and other avenues have to be guided and provided by a professional, so that the consumers will be able to complete the journey in a safe manner. That is the point you wanted to highlight, right?
Right.
Thank
Exactly.
Yeah. Because there is so much of nicotine illiteracy among doctors also, because I would like Dr. Jayashree's opinion on this. In my earlier research, when I was discussing about tobacco harm reduction perceptions among healthcare professionals, they are in favor of nicotine replacement therapy products like nicotine gums, patches, prescribing these products as tobacco cessation tools, madam. But when we discuss about these other avenues like e-cigarettes, they are not in favor of, mentioning these products as alternatives or tobacco harm reduction tools. What could be the reason why healthcare providers are not in favor of the second option of products like e-cigarettes and others, but they are more in favor of nicotine replacement therapy, pharmacy products like gums and patches?
One thing, they are advertised more than e-cigarettes. And,
Yes.
and the thing is, they think the vapor coming from the e-cigarettes can be hazardous to a second-hand smoker, the person next to us. So that is the common belief the doctors have. And again, that is one of the reasons why even our country banned it. Apart from that, both the nicotine used in an e-cigarette or else in a nicotine gum or a patch is a nicotine.
Yes.
The constituent is the same way, but the form in which you use the nicotine is different.
Yes.
So I think even nicotine gum and a patch has the same amount of nicotine as
But
like a e-cigarettes.
yeah, but there is this misperception that the vape, which is released during vaping, is hazardous to the bystanders. That is a perception among the people. Asa, you are the right person for us to have an understanding here. Is it a true? I believe it is a misperception. Is it?
It is.
Can you just?
I mean, it is not true. It is a misperception.
Yeah. Can you
It's just a vapor. And there are lots of scientific results proving that the vapor coming out from people who vape from, of course, the word we use is electronic cigarette, or the more formal word would be vaporizer. It's like steam coming out. Of course, I never deny that there are some substances contained in the what we call e-liquid or e-juice. So the liquid used to make it vaporize and make it like a vapor. That's why it's called vapor. So there are some very minute, but we have to compare. Then we compare what? What we compare is we compare to the smoke from combustible cigarettes. Of course, you know, like clean air is cleaner. But then again, I would argue that the vapor from electronic cigarette is definitely safer than the air in the street in any major city in the world. I mean, I'm not talking any major city in the world. You go, there are ways to measure the toxicity, PM 2.5 and everything else. And, you know, if you want to be fair, you have to do that. If you go into a clean room, of course, inside the clean room, you say, this is very nice. But, you know, you step outside your house, it's another story. It's very different. This is exactly the same. What we are trying to say is that, okay, let's call it electronic cigarette. Then it's a form of cigarette. I would 100% agree that say, let's not smoke at all. Let's not bring in any foreign substances into our body. You shouldn't smoke. You shouldn't vape. You shouldn't drink. You shouldn't drive dangerously. You shouldn't get on a motorcycle without knowing how to ride and just go ride. You shouldn't start with 1,000cc motorcycles if you don't know how to use bicycle, for example. But if you are already a smoker, then it's another story. That's why we are trying to tell the government, say, give us a choice. You know, it had been proven that electronic cigarettes, the harm is about, I'm not even gonna say because there are a lot of debates on the numbers, but definitely lower. And you can look into the substances or the ingredients and everything. And most of all, there is no combustion. Combustion brings about tar. Tar is what coated, and then you know you are the
doctors.
oral doctor itself, not even the lung, but just the mouth. You can tell from the smokers, you know, you have like they can have like us, we have like pearly white teeth and whatnot, but smokers, no, you don't. That the fingers became yellow and the teeth, the gum, the tongue, everything. I mean, so that's very easy to see, but we have to educate people. Like Dr. Sri, you just said that misconception came from miscommunication and misinformation.
Asa, I remember Public Health England and the Cochrane review has clearly established the relative superiority of electronic nicotine delivery system to combustible cigarettes. It's 99% relatively safer than combustible cigarettes, right? So as you correctly highlighted, we are comparing the relative safety to combustible cigarettes, right? Yes. Thank you so much for giving a variety of examples and the ingredients involved in this electronic nicotine delivery system. And as Madam has highlighted, it is a safer delivery of nicotine compared to the combustible cigarettes. And the nicotine replacement therapies also deliver nicotine in different formats, and this is one form of delivering the nicotine. And madam, in your article, you have highlighted Thailand as one of the example of reconsidering the scientific evidence emerging and reevaluating their public policies. Can you just highlight, like when you wrote this article, what was the reason you brought in Thailand as one of the example in your article? And we have Asa here to connect the threads for us.
I think both the anti-tobacco policies in India and Thailand are similar.
Yes.
As he said, both the taxation policies are similar.
Yes.
The main thing they are doing is banning on smoking in public places, then increasing the prices. And apart from that, they are banning the advertisement and they are providing some smoke-free areas. But they are not encouraging the other modes of nicotine replacement therapy. Whereas now in Thailand, now there is a speculation regarding it. Why should we allow it? Like a thing. But whereas in India, it's still not a topic of discussion yet. So we hope in the future. So when we compare a country like similar to us in the same situation, maybe we can also think about in the future.
Very good, very interesting. The way you draw the comparisons and parallels and also hope for similarities in future. Now I would like Asa to connect these dots and project what could be the scope of transformational tobacco policies in India, drawing the example of Thailand.
We have to think of it this way. One other thing is that sometimes governments in any country, I'm not specific, let's say okay, in India or in Thailand. For example, let me use our country. When we first start to ban, we use New Zealand as an example. The doctors in our country say, hey, look at New Zealand. They are very similar to us and they ban electronic cigarette. Right now, we are trying to say, hey, you said, let's follow New Zealand, they ban. Right now, New Zealand already lifted the ban. Why not follow them? And they just turn the blind eye. So hopefully we will succeed on our part, and also with a bigger hope that India will follow. Like I said, I mentioned when I started speaking here, the whole situation in Thailand started in India. You guys probably didn't know this, but it was in 2016 that they started rallying about safer nicotine product, or what we call tobacco harm reduction. And they just don't want to accept the concept of harm reduction. But, in the end, Thailand or India, they will have to come to the senses, and we, the people, are still the voices. And, I just want to invite everyone who listen and tune in to us, or right now or later, or get a glimpse to see what Dr. Jayashree had mentioned, and her slides, and what we mentioned, what we talk about during these discussions, and come to kind of senses and say, hey, this is our right. We have a right to choose of what is safer for us. And if the government, any government, if they don't want to do that, then, we have a problem. And if the government know that and knows that, more voices are to be heard, and they will hear us sooner or later. And, let's hope that it will be sooner for the sake of the people. I had mentioned behind the mic before we started that I'm also in medical field. So yeah, I also do care about other people. I'm free now. I stopped smoking for 10 years, at least 10 years already. And my health is in excellent shape and form. So I'm glad I got out of that, but I don't want to be selfish. I got out, and I want other people to get out as well. So that's one of my passion, what I'm fighting for. And hopefully we can fight together, India and Thai. We are just families. Some historians said Thai people came from India. So partially it is true. My ancestors, a little bit also from India.
Yeah, because your name, at least Gupta, is definitely a common name in India.
It's exact same meaning. the exact same meaning, yeah.
Yeah, we believe you are part Indian. So you are definitely an Indian now that you are part of our webinar. So coming back to the webinar, we'll talk a little bit about the Conference of Parties, which is happening to be the next month. And Dr. Jayashree, you may be aware about this WHO event, which is scheduled to happen November 8th onwards in foreign shores. And do you believe like the discussions happening there definitely are going to influence the trends and major shifts regarding tobacco policies? And your presentation also helped us understand what are the directions the governments are taking, and also in the middle of pandemic the focus may be in containing the pandemic and minimizing the burden of pandemic related health issues. Tobacco in a country like India with multiple other health issues may not be figuring on the priority list, but even then, as a doctor, as an oral medicine specialist, and someone highlighting the importance of tobacco harm reduction, because in your presentation you talked about demand reduction, supply reduction. Now, with COP happening in the very much near future, if at all we have to send out a request or some kind of consideration for WHO to include harm reduction, as a practitioner, can you summarize like what would be your recommendation for the government? How can we impress upon the governments and congregating there why harm reduction should be their core strategy?
Talking about the harm reduction on tobacco products, they mainly focus only on cigarettes. I want them to focus apart from cigarettes like BD, pan masala, gutka, the products which are commonly used in our country. So these products, how to manage them also should be discussed in this conference, because they have a huge impact on our policy making things. So I wish they would include these things. And apart from that, again, whether there should be a ban on e-cigarettes or not, another discussion should be held, as India will listen to the WHO framework convention. So I hope they will talk about these things. And again, then the use of tobacco to minor kids, like below 18 years. And what are the things that India is doing for those people is not yet very clear actually. Though there are many laws, like there is, they are putting a huge amount of fine. Even there is a law regarding it, but there is no awareness about it. So they should talk about this, because in this pandemic, we are seeing many people using drugs. There are many cases of drug abuse. So in that kind, if the person is first used to a tobacco, later on he can even get the use to a drug. So all kind of illegal activities should be stopped, and that should be a main focus in a country like in India, when children are not going to schools at this time. So when they are at home, they could influence by other people at the neighborhood. So they should talk about this issue in the current matter fact of thing. Apart from that, I think how this law are implemented. See, the taxation thing, I'm not okay with it. If you're going to raise the price for BDs, even lower income people, when he is used to smoke 10 to 12 BDs, what will be the price he's going to buy it? So there should be a clear policy regarding it about the taxation thing. And apart from that, again, I stress on the smokeless tobacco forms, because they are the one major cause for the oral cancers, and there is no much awareness regarding it. And the awareness should be created. What is oral cancer and what causes oral cancer are not discussed. And I think in a policy making discussion about any like national tobacco control program, it never discusses about what is the role of a dentist and what is the role of a community medicine specialist people in this. When there is a tobacco cessation clinic, I can see a public health worker. Though he can give some training to him, he's not the qualified person to do the counseling. He can do a counseling, but he can't treat that patient. In such a kind of a thing, there should be a group of psychiatrists along with a dentist and a public health professional, because this is a public health issue and they should be included in it. And our country's policy should be directed towards these things. It is not only just setting up a clinic is not enough. See, getting people to use these things first they should be aware of such clinics there. And the government should spread things about these things, how to quit tobacco. Only if you want to advise regarding the harmful effects of tobacco, people won't listen to that. Apart from that, we have to be accessible to these kind of clinics in our country, and these issues should be addressed. That's my opinion.
Thank you for sharing this comprehensive range of issues that the government can bring in together in the policy making. Asa, what are your thoughts when COP is happening? Harm reduction, how can it be highlighted or flagged by high burden countries like LMIC, which are facing the brunt of the tobacco-induced diseases?
First, let me clarify something first. We should say FCTC COP. Because there are lots and lots and lots of conference of party using the original COP COP. But one weird thing about COP is a conference of parties that discuss issues that happen all over the world under the umbrella of World Health Organization. But what is funny is that, for example, there are COPs, I think like 26 or something, on environmental, global warming and environmental impact and things like that. And they invite all stakeholders to participate. You know, you can be a big oil company, you can be a tree hugger, you can be anything, you can register, you can observe, and you can participate, but not FCTC. There are so many rules try to forbid, you know, people like me. And like, I really agree with you, you know, Dr. Jayashree saying, you know, like, why not invite dentists, people who are involved, and really people, stakeholders. No, and also, you know, you may not know this, but most of the decisions are being made before the meeting itself. So it's kind of like a get together, but this year it's going to be an online conference. So the results, the decisions and everything had been mailed to attendees. And I had been to one of the meeting and was fortunate enough to just, you know, be right there at the venue. And but we got thrown out, you know, literally. And but we get to watch like that. There's an online thingy going on, and but we knew since then. But actually, we knew before then that, especially for LMICs, you know, as low and middle income countries, they don't really care much, and they just want to do whatever they deem right, and they have some grudge again, like big tobacco, and they say, okay, let's go and kill the big tobacco, and they don't care who's the they don't care about collateral damages, they don't care who died in their path, but they just want to do it their way. And one of the big sponsors are the person who's like head over heels against all kind of tobacco, including electronic cigarette, and is the person who doesn't give a damn about harm reduction, any form of harm reduction. So it's a weird thing going on. And so that's why we said, you know, if it's about us, if it concerns us, why not involve us? This is everything about us. Without us, it's FCTC COP. So it is frustrating, but, you know, hopefully the government will listen, you know, like I say, like I mentioned, like you mentioned, you know, if we shout out and we ask our government, you as dentists, as doctors, you know, us as consumers, we shout out loud enough, long enough, I hope that the government will listen and at least send delegates who's at least sensible, have some voice, like, you know, New Zealand, England, they just representative from England, they just stand up and speak out and say, hey, why are all this grudge against vaping when vaping had proven to be like the best form so far for smoking cessations? We're not saying, they say, hey, we're not saying that electronic cigarette is a form of cessation, but it's the best way to get people to stop smoking. So why are you so against it? And, you know, like Shri had said, 99%, they started with 95 and more evidence came out. Now it's 98, 99% safer. So yeah, So yeah, you have a passion, I have a passion. I can tell from your speech and everything, you know, we have passion. So let's continue our passion, and we have to fight, especially for our people.
Yes, that is where Dr. Jayashree's article highlights the urgent need to re-examine India's public policy. And she currently mentions in our webinar also, the focus has been on smoking, but she wants to draw attention on smokeless tobacco also, including BDs, because that is where the low-income population in India accesses these BDs and smokeless forms of tobacco. And she also highlights in the article the need to open the debate on legalizing, or what are the avenues to access these other harm reduction products, including electronic nicotine delivery systems. That is one option for smokers, but Madam has been highlighting repeatedly the need for including harm reduction options even for smokeless tobacco users, because the nicotine replacement therapy options like nicotine gums and patches and lozenges, all these are very costly compared to gutka and pan parag, which they can get for 10-20 rupees. Gums and patches are hundreds rupees. So a low income group person can go and buy gutka and pan parag and get addicted, rather than to get de-addicted and stop using them, he cannot buy a gum. So unless a drastic rethinking happens about these public policies, even to help people to quit either through nicotine replacement therapy, pharmaceutical products, or consumer products like a harm reduction product, the public policies have to rethink, come out of the box, and think and take along multidisciplinary professionals, consumers. As Asa says, nothing about us without us. And these kind of debates involving multidisciplinary professionals, consumers, advocates, researchers across the globe helps us enrich our knowledge. And as he says, shouting is the only option available to us right now, it looks like. And COP FCTC happening next month should also be accessible to everyone. As you said, the COP26 climate thing, everyone can attend it. It's open gallery thing, whereas COP FCTC is not. The point is well noted, Asa. And with this, I would like finally to thank both the speakers, Dr. Jayashree Gopinath, oral medicine specialist at Ragas Dental College. Madam, we thank you so much for taking us through the evolutionary policy making related to tobacco in India. And also thank Asa Saligupta for joining us and helping us understand the connection between India and Thailand. We are connected. We may not be Siamese twins, but we look like we have some connection there. Hopefully the journey will lead us to the safer options for consumers and also people using tobacco. And here I would like to conclude the monthly webinar series of Association for Harm Reduction Education and Research. We thank all the audience and viewers who joined us for this webinar series. Hopefully we will engage with both the panelists at a future time, in a better time, and talk about our journey in achieving what we wanted to achieve. Right. Thank you so much.
Thank you, Dr. Sush.
Thank you, madam. Thank you, Asa. Bye.